Our next presenter is Dr. Scrase from the New Mexico Human Services Department. I hope that you've been able to join us.
Yes, indeed, I'm here. Could everybody just turn in on their camera at least for just 1 minute so I can see who all I'm talking to today?
Pat, you can unshare if you want for a second. That way we can be a larger screen.
And this is the, I'm just going to move you all to another location so I can see my own presentation. Hi, everybody. Thanks for revealing yourselves there. So I see we have a few people who are still maybe weighing their choice of, do I want to become a scientist or not? Particularly Lana there. Especially for you younger folks on the line who are thinking about what you want to do, it's my hope, and actually the whole reason I took this assignment was to see if I could persuade some of you to think about a career in science, because we need more folks like that here in New Mexico. So I'm just looking for the presentation. Is this? No, it's not it. So give me a second. I should have been ready. I was just sitting there waiting. I was happy to see some of the New Mexico sites on the video. So that was nice to see some of our work. And what we're going to talk about today is what exactly is modeling and why the heck are we doing it, and what applications does it have for the state during the COVID pandemic. And so can you see a screen and a couple pictures, a doctor, a child, a mom and her daughter?
Yes, we can. We can see it.
Perfect. Also want to thank Alex Castillo-Smith, who's on the line, and she does a lot of work pulling this information together and this data together. Okay, here we go. My computer gets clunky every day around 1 o'clock, and I'm not sure why. But you know what we're going to talk about a little bit today is modeling, and what it involves is making a representation of something. So probably when you're younger, or maybe this fall, you'll be in the science fair and building a small volcano, or if you're, in a classroom where you're having a mini presidential election to learn things about a bigger election. It's really anything that represents something else, and usually that something else is you start on a smaller scale to understand things on a bigger scale. I remember a lot of algebra story problems, and we probably all do modeling ourselves. I mean, if you have an hour to get to an event and it's 50 miles away and you're driving 45 miles an hour, you know that you're going to be late, right? That's sort of modeling. It's taking data you have right now, the current time, your time of arrival, the time you need to be there, the speed you're traveling, and you put that data together to decide what's going to happen in the future, so you'll either just be late, or maybe you'll check and you'll find out the speed limit is 55 and you'll speed up and you'll get there on time. In COVID, what we're mainly modeling is for the future. We're taking the information we have now and looking out ahead to see what trends we're seeing so that we can be prepared. And I'll explain that a little bit more using this example. So what we're doing is, at the beginning of modeling involves asking a ton of questions and nailing down a lot of different assumptions about the work we're doing. So, we started back in March with what do we know about the virus? And the answer was actually not very much. The pandemic was new. We were getting some information about number of cases and overwhelmed hospitals and intensive care units in China, and then Italy, and then New York City, with very little data about the virus. There's a lot of things we thought about the virus that aren't true, although I was suspicious from the start about some of them. But, so one thing to know how many cases there are going to be in the future is, well, how many people on average does one person who's infected infect, how many people do they infect other people? So, and with COVID virus, for example, and I'll talk about this a little bit more in a minute, but every one person infects 3 other people if you don't do anything to try to stop it. how much time from infection to symptoms. We knew a little bit about that at the beginning. We've been using 5.1 days, and that hasn't changed really much at all. How much time until one can infect others? It used to be believed that people without symptoms could not infect others. I was pretty sure that was not true, and we did not assume that. We acted as though, like with influenza, the flu, people could infect others before they had any symptoms. And how much time is that? And it turns out about 36 to 48 hours before you get symptoms, you can infect others. And now we know, this question is, it wasn't even on there, is that there's a bunch of people who walk around with COVID that don't have any symptoms at all, and they can infect other people. We also need to know, to predict the future, what percent of patients with COVID are we going to know about? Because of course, there are more people out there than just the ones we're testing. How many people with COVID will require hospitalization or an ICU or a ventilator? How many folks will die? And I'll explain to you why these questions are more important, but you know, there are names for all of these different variables. And so we had to, before we could build the model, define what each of these were and make estimates based on best guesses about what we could do. And I want to highlight R0, R0 is that 3.0 people infected by every one person with COVID with no countermeasures. R effective is how many people does one person infect with countermeasures, and which countermeasures will drive it down even more. I won't go through all these definitions, but I'm gonna just keep going. So, and also you want to know, well, what can we do to reduce the spread of the virus? Modeling doesn't help you if you're not going to do anything with the data. If you're just going to watch and see what happens, like if you're going to say, oops, you know, in 4 weeks, our ICUs will be completely overwhelmed, but you're not going to do anything with that information, then don't bother taking all the time and energy to set up the model. You know, what increases transmission? Well, we know that closed spaces with poor ventilation do increase your chances of getting COVID. That doesn't mean outdoors is safe. It's just indoor spaces with poor ventilation. Close contact, if you're within 6 feet of people. Prolonged contact for more than 3 minutes without masks, 10 minutes with masks is what we use in New Mexico. So that's what increases transmission. You know, of course, coughing, sneezing into someone's face or eyes. I didn't put those on there because that everybody kind of understands that. What decreases transmission? Well, staying away from other people, staying at home. You know, don't go to school or work. If you're sick, if you're out, always wear a mask, no matter what, no matter what. And at this point, can you guys see me, or can you only see my screen?
We can see you and your screen.
Okay, perfect. So I feel strongly about this. I'm going to do this again. I want to show you how to wear a mask. It's really important. See, I've got this mask on. It's tight. There's no spaces here. It's crimped on my nose. No spaces here. And notice the most important thing is it's covering both my nose and my mouth. And I still go out and I see people, you know, wearing their masks like this. And, you know, I always say on this one, you know, where do we stick the swab when we're testing you for COVID? We stick it in your nose, and that's because the most COVID is in your nose. So you're really doing a disservice to humanity by not keeping your nose covered. But my favorite one is this one, where people just cover their chin. And we don't have good scientific data, but I'm pretty sure that COVID does not enter the human body through the pores in your chin. So this will do no good. This is how to wear a mask. And the new public health regulations say that we all should be wearing a mask anytime we're anywhere outside our own homes, and that does include exercise. Staying away from people, 6 feet or 2 meters. There's a 6-inch difference, but Europe uses 2 meters. Hygiene, hand washing, keeping surfaces clean, coughing into a tissue. We all know that. So the goal of modeling is to reduce deaths, okay? That's what we're really trying to do, is have less New Mexicans die. So the way we get there is tracking the number of tests we're doing to identify cases. When we get those cases, we call them up. We find out everyone that they've been in contact with. We ask them to stay safe and in contact with no one for 10 days. We call up all their contacts and urge them to be in quarantine for 10 to 14 days. When we do that, these folks have no contact with other people, which reduces the spread of disease, which reduces hospitalizations, intensive care units, and people on ventilators. It reduces the number of people using those scarce resources. And that's how we reduce deaths. So we spend a lot of time trying to figure out how do we modify this cycle to reduce cases as much as we can at the beginning so that we can reduce deaths. Our model is enhanced SIR model. It stands for where we track susceptible people, those who are infectious, those who are recovered. Of course, people who get COVID move generally from susceptible to infectious to recovered, and most of the time. And so we have that model. Presbyterian Health Plan is working with the state and Los Alamos National Laboratory to pull this model together. We meet every week, actually twice a week, to talk about the details of modeling. And the model incorporates a variety of real-time data. So every day, at the end of the day, we take all the data from today. For example, today we'll take all the data from today and put it into the system, the number of cases, the testing rates, where the cases are, what kind of outcomes we're having in terms of recovery. We put in health system resource capacity, which we measure every day. And we also look at, and we even build in poverty rates, disease rates, other social determinants of health to predict what's going to happen in New Mexico. Because counties have such small number of cases, with the exception of McKinley, San Juan, Bernalillo, and Doñana, we tend to model by region. We do the whole state as one, and we model by each of these 5 regions, which are set up based on DOH's planning regions. And we put this model online every Tuesday and post it. I'll show you that in a minute. And so how does modeling, when we have all this information and data, how do we use it then to make public policy decisions? Like, I'm imagining there's some of you here who are already annoyed with me just because someone in your family owns a restaurant and you think I'm the one who decided that we had to close restaurants again, which I am not. But you know, let's talk a little bit about how we do this. So if you go to the website, and Alex will provide this to all of you, you can just click. If you click on the pictures, it'll take you there. This is the actual website, okay? And so you can see here there are 4 different categories of gating criteria. One is how rapidly is COVID spreading? How good are we doing at testing? How are we doing at contact tracing and isolation? And how are we doing with statewide healthcare system capacity? So 4 categories, 6 measures. I'll say a little bit more about rate of spread, but that's that R effective we were talking about. And you can see here, and hopefully this is coming through okay, that, you know, we track it for the whole state. And remember, and you guys like math, so you'll understand this. Anything above 1 means that the 1 is down here actually, means cases will continue to grow, right? If one person spreads the infection to 1.05 people or 1.2 people, and you keep multiplying that out, you'll have more and more cases. However, once it gets below 1, like it was on June 10th, where one person gave it to 0.87 people, and I know I'm a physician, so I know there isn't such a thing as 0.87 people, and if you want to multiply these numbers by 100, so 100 people give it to 87 people, you can quickly see how it would die out over time. We monitor that by region as well. Going back, testing, our governor is very, very devoted to testing and has really been pushing it. And you can see we went from, and this doesn't even go back all the way when we had no testing, but even from the beginning of May, we've more than doubled our average amount of testing. Since you're STEM people, and this is a talk about modeling, I'll point out a few things. One is we always have a target line here. We use 7-day rolling averages because if we didn't, the data would be very choppy, and one day we'd be meeting the target and the next day we'd be below, and the next day we'd be above, and the next day we'd be below. So 7-day rolling average takes all the values for the previous 7 days, and for that day you're doing it, puts the average of those numbers. So that's that's one thing that's helped us interpret the data. Next category, briefly, is the contact tracing and isolation. And maybe you should have someone from DOH come and talk about this, but that's that action where we call people up and we get their information and track down their contacts and ask them to isolate. You can see we've fallen quite a bit behind here, and that's only in the last week because we've had such high case counts. Because when we did reopen, people didn't exactly follow the public health orders to the letter. They did more than what I think the public health orders allowed. Now you get down here to the adult ICU beds occupied across the New Mexico hub hospitals, and we track that closely. On any given day, we are licensed for a total of 230 hospital beds, and you can see we've basically been above our license capacity now for over a month. However, our hospitals, in working together, have found a way to have surge beds, which gets us all the way up to 460. Once we get there, then we're in real trouble. We potentially could double up people in rooms, but this is when we start running out of healthcare personnel, ventilators, and the like. And so some people say, well, why don't we just, isn't the most accurate way to track the seriousness of COVID to just simply look at people in the hospital or look at people in the ICU? And the answer is absolutely yes. That is the best way to do it. No question about it. The problem with that, though, is if you wait until your ICUs are over full to start acting, then it's over. Like you're never, any change you make at any point in this curve is going to take 2 to 3 weeks to actually show up in case numbers. And so modeling gives us the 2 to 3 to 4 week head start on the future, so we can start doing interventions in advance. I think I'm gonna move back now to the presentation. Hopefully that will come up, although this is what happened to me last time as well. So give me a second here. All right, so are we back on my PowerPoint, people?
I still see a
Yes. Yes, David, I see the public health gating criteria slide.
Okay, so, and then for the modeling itself, there's a bunch of resources. I'm not gonna spend a lot of time, but you can go here and click here on the website and you can get the latest presentation. And if there are data geeks out here, which I assume there's a bunch of them, and let me keep myself out of trouble by not full screening this. What did I do? This. Here we go. You can see a whole slide presentation with just an enormous amount of data that we use to, look at prevalence. I'm not going to go through it, but per 100,000 population by area of the state, we've got data by age, and you can see this emerging growth of cases in younger people, 20 to 40 now, account for, this last week, it was actually, under 40 was more than half the cases. And so I think a lot of you, like me, thought of COVID as a disease of older people, but really most of the cases now are in younger people. So I'm gonna leave you to your own devices to look that up and look through it a little bit more. And then as a special treat, which we don't normally do, which I thought I had a link here. Oh, I think I do have a link. Just a second, let me try it this way. There we go. I'm gonna take you, give me a second. Do I have 3 more minutes so I can show you this? Because I think you'll like it.
You sure do.
Okay, so you might have noticed that I have dual factor authentication here. So let me let myself in. Takes a minute for this to come up, but I just want to show you what a model actually looks like when you're, or do you all already know this? Do you already know this, or?
Well, a lot of us are new at it, so it's always good to get a nice.
Okay, good. And what I'm going to show you today is the model that we use, that I use every day. And it looks absolutely nothing, except for the color scheme, like it did in late March when we brought it up. And so it's a continuous improvement effort. We're constantly suggesting other alterations to the model. Most of what I'll show you are alterations to the model that have come as a result of discussions amongst people on the modeling team. And so here, remember at the beginning how I talked about putting all your assumptions in? So we put these in here. Okay, so, and I think we had an infection fatality rate in there at the beginning, which is what percent of people who get COVID will pass away. But you know, the lag between new cases and hospitalizations, we weren't even thinking about that. It turns out it's about 14 days. How long between an uptick in new cases going up in number and when we see more deaths, it's about 21 days. You can set this to start on any day. So if this is the day when schools reopen, you can say, you know, we think we're going to have about let's just say a 25% increase in transmission when schools open, you know, or let's say 30 since I hit it again. And then it automatically calculates this. It tells us what the spread rates are currently, how much they're going to go up later. It shows us that SIR model, susceptible coming down, infected going up. Notice it starts, it's actually going to start us on August 12th and take us through a whole year of time. We can look at the number of cases that are going to happen. Of course, it's all dependent on the assumptions we put in. This is the one I spend like a ton of time worrying about and what wakes me up at night. So blue curve is the number of hospital beds we're going to need. Blue line is the number we have in extreme circumstances. Red line is the number of ventilators we're going to need. Red line is the number we have. Neither of those cross. Neither of those colored lines touch each other. However, ICU beds are more scarce resource, gets completely full when we fill up our remaining available beds around, it looks like about 90 days from today. And then we have a long period where we're in real big trouble. And then we finally go back down. And this also assumes that when all this horrible stuff happens, the public hunkers down again, stays back at home and watches. But there's all this data that just, we can put in any assumptions, test what it's going to look like. We're also, because the, and I thought I had a couple other slides on that, because the R effective, the spread rate is getting a little wacky on us. We're learning that some measures work well when cases are going up, some work better when cases are going down. We're now tracking growth rates too. And you can see this is a daily growth rate. This is pretty scary. If you've learned about exponents, you can see it's about 1.3%. And that's, I mean, so 30 days from now, the number of cases will be whatever they are today times 1.03 raised to the 30th power. That it might not sound like a lot, but do the math and you'll see what it is. So here's an example I was talking about. We're using our effective in our gating criteria, but it's actually looking pretty good right now. And we have the most cases we've ever had. So we have a lot of debates and discussions of, should we really be using this measure now? It worked really well back here, but now it doesn't make any sense. And so we're looking at the growth rates as well. You can see we have confidence limits and a lot of data that we use to make decisions. We've got rolling average of new cases. I probably should have started with this slide about why I don't get enough sleep. You know, we thought we were over our peak around May 1st, coming down, little outbreak in Ontario County. And then we reopened the economy about here, and in other states and countries, there's about a 5-week lag between reopening things and slopes like this. We thought we were just opening a teeny bit of activity that would enable us to have enough room to take care of the increased cases. I think the people of New Mexico may have seen it differently and thought we're headed back to normal life now. And so I don't want to dwell too much on any of these other numbers, but this goes on for a while. And you see we have county specific data, all that other data with the multiple lines is region specific data. So I personally think, you know, I've been a scientist, I've been a physician, I'm a physician, been doing it all my life. I kind of think it's the coolest, this part of my career is the coolest part of my career. I'm a huge mathematics fan, love the idea that we can take huge volumes of data, and distill it down into a model that will allow us actually to do things that will save lives. And as we close, I want to talk about that a little bit more, that, you know, as a result of identifying this overflow in ICUs about 3 months ago, we brought all our major delivery systems together in the state. They came together, set up a similar call center, figured out together how to expand ICU beds to double them, you know, worked with the medical advisory team, which is a part of DOH that I've been leading, to give advice about what kind of ventilators to buy. So it's actually using science to drive public policy decisions, which, as I look out on the news, might be becoming increasingly more and more rare, but something that I think is a huge role for scientists all over America and the world going forward, because in the COVID pandemic, we have this great opportunity to really save lives. Now, somehow, oh, here I am. I'm going to stop my screen sharing and take some questions if we have time. If we don't, that's fine too.
Dr. Scrase, there's a question in the chat box that is asking, is the state developing a digital contacting tracing app or adopting one from another state? Is there any consideration for that at the moment?
Yeah, there is. I think we're working with Accenture, and they've piloted an application like that in Massachusetts. The one thing that drives me nuts is anytime any process uses paper. So we do really have people calling on the phone, asking people's name and address and phone number and all the people they've contacted and the dates and the places they went to. And there's absolutely no reason that when your case is positive, you couldn't get a call saying, hey, you tested positive for COVID. This is the Department of Health. We're going to be sending a application to your email or your phone in the next 10 minutes. And please, you know, fill it out within an hour and get it back to us so we can expedite your safety and the safety of the people you've contacted. That's the vision for that. Secretary Kunkel oversees that part of this operation, but something I've been really encouraging everybody to look at hard. So good question.
If I could follow up on that, I'm aware of the contact tracing for the callers and the case flow management. I'm talking, I guess, more on the Apple, Google exposure API, and then states, you know, where it's tracking exposure with the apps. But then the states, it's incumbent on the states to write apps that leverage that. So do you know if New Mexico is writing their own, or are they adopting one from another state?
We're not doing that. You know, it's really tricky when you do this work to respect the line between personal privacy and public need. And so I know that an app like that was introduced in Australia and only had about a 12% uptick. And particularly if people who have COVID don't sign on, we don't have any regulations or laws that would require an individual to geolocate publicly, which really is what it would be. I mean, it would be de-identified, but you would be basically telling the government where you were at every second for 14 days. And so we didn't think that would be an easy sell.
If there was a technical way not to expose it to the government, would New Mexico consider adopting it? Because I think it's something that New Mexico could invent, right? When you think about distributed intelligence and bottom-up computation, I think, would the state consider something like that? And that would actually be pretty inventive, yeah?
Yeah, I think we would. I think the theory maybe would be that if the state paid an independent third-party contractor to write the app and administer the app, and the person from DOH was the one who called you and told you you'd be hearing from those people, I think if you did a survey of public opinion, I'm guessing that maybe 40 to 60% of people would still think somehow the government was, I mean, 40 to 60% of people already think the government's tracking them and following them.
Right.
So that it's just a sort of we haven't figured out a way to finesse that personal privacy issue, but it's a great question. And, you know, it would be a lot, I would probably be for and willing to do myself something that, started beeping on my phone if I was COVID positive and still in recovery, time, and I was out like I shouldn't be and warned other people. I would be for that, but I don't think I'm a typical person. So
thank you.
So I'm going to have to move us on our project. I know there's a lot of things that we could be talking about as far as policy and information. sensitivity. And I think we need to get back to the presentation at hand. Dr. Scrase, I really appreciate you spending the time with us. I know you have a busy schedule, and I know a lot of people have really got a lot out of your, especially the internal look at your modeling tools.
Sure. Well, thanks everybody for your time. There's ways of getting a hold of Alex and I. You can email us. It's actually, if you want a quick answer, you can email Alex and she'll talk with me and we'll get it to you. But appreciate your interest in this, and I hope that those of you I saw on camera that appeared to me to be somewhat younger and still thinking about what career you want to do could see another way you could just take science and use it to save lives. It doesn't involve having to go to medical school and do an internship and residency or nursing school or other health professional schools. So thanks, and anything else I can do for you, just keep us posted.